Regardless of the cause of the brain injury, there are some common complications and some different levels of consciousness that you need to be aware of. The purpose of this PowerPoint is to introduce you to these. Now, there are some special things to consider when working with patients that have had a brain injury. One thing I can tell you is that you should expect the unexpected. You never know how a person with a brain injury is going to present. You can have anything from physical dysfunction, you can have cognitive dysfunction, this person could be behavioral, and you can also throw in some sort of medical involvement. Let's say the person has fallen off a ladder and hit their head, and they suffered a brain injury, they're in a low level of understanding and cognition, and they also happen to have broken their arm. That person is not able to understand the fact that they are non-weight bearing on their arm. So this is a very difficult situation to handle, but it's part of what you do when working with a person with a brain injury. You should also consider that a person who's had a brain injury might never fully recover. They might not ever get to be the person they were before. And if this person is, let's say, head of the household, and they have 3 kids and they're providing the only income for their family, they might not be able to go back to work. This is going to have a severe economic impact on the lifestyle of that family. Also consider that oftentimes people with brain injury are married, and they might never get back to being who they were before, and their spouse might not be able to accept this fact. So their spouse might just choose to move on and leave the person who's had a brain injury. This slide shows some common complications that can happen in patients who suffered a brain injury. The first of these patients might have a raised intracranial pressure, or ICP. Remember that normal intracranial pressure is up to 15 millimeters of mercury. A heterotopic ossification is formation of a bony deposit somewhere. The next slide we'll talk a little bit more about heterotopic ossification. Another complication is decubitus ulcers in response to being immobile and lack of proper positioning and or turning when the patient is in bed. Another is DVT. We've been exposed to the concept of DVTs and how they form and the fact that they can possibly cause pulmonary embolisms in Med-Surg 3. Autonomic dysfunction, specifically something called a neurostorm. We'll talk more about that later on in the semester. These patients can have infections and pulmonary problems just because there is no motion. And they could also present with amnesia. And we'll talk about different kinds of amnesia later on in this PowerPoint. As I mentioned, heterotopic ossification is the formation of bone in a place where it's not supposed to be. About 5 to 20% of patients with either brain injury or spinal cord injury will develop heterotopic ossification, and nobody really knows why or what causes it. Males seem to be more predisposed to HO in a 2-to-1 ratio than females. And if you have a patient that presents with a sudden loss of range of motion in a joint, swelling in the same area, local heat and erythema, and a non-septic fever, chances are good that that patient may have developed heterotopic ossification. This needs to be diagnosed via X-ray, and if the person does have HO, vigorous stretching should be avoided. Another complication to be aware of is amnesia. Amnesia can be one of 3 different kinds. The first kind is called retrograde, and it's a partial or total loss of the ability to recall events during the period immediately before the patient suffered a brain injury. Post-traumatic amnesia would be the loss of the ability to recall events that happened between the accident and the point where that person's memory is restored. O'Sullivan mentions that post-traumatic amnesia is going to be one of the important predictors for recovery following a brain injury, or the length of post-traumatic amnesia. Another kind of amnesia is anterograde, and that is the inability to develop short-term memories after the brain injury has occurred. So 3 kinds: retrograde, post-traumatic, and anterograde. And post-traumatic is going to be more concerned with recovery following the patient's brain injury.
This table is right out of your Sullivan text, and it demonstrates some characteristics of traumatic brain injury that you can use to characterize the brain injury as either mild, moderate, or severe. For a mild TBI, loss of consciousness is going to be less than 30 minutes. For a moderate, it's going to be less than a day. And for severe, could be more than a day. So loss of consciousness, you should be thinking coma. Alteration of consciousness, that's going to be a change in the patient's level of consciousness. And we've talked about this before, as a person can be in a coma, or they can be stuporous, or lethargic, and alert. Okay, an alteration of consciousness is going to be anything that isn't alert. Mild TBI, it could be brief or about a day. A moderate TBI is going to be greater than a day, as well as a severe TBI is going to be greater than a day. For post-traumatic amnesia, for a mild TBI, you might have PTA for less than a day. For a moderate TBI, it's going to be less than a week. And for a severe TBI, it can be more than a week. And Glasgow Coma Scale, something we haven't talked about yet, but we will do this outcome measure in lab. And 13 to 15 is the score on the GCS that's going to indicate a mild TBI. A 9 to 12 is going to be a moderate TBI. And a severe TBI is going to be less than 9.
As far as defining what a coma is, there's something called the Renshaw levels of consciousness, which we'll talk about next class. And a coma is considered Renshaw level 1, where the person does not respond to, in any way, to any kind of stimuli. Their eyes do not open. They're unaware of auditory and visual stimuli. There's absolutely no communication, no moaning, no movement at all. That's considered a coma. Now, next step up from a coma is what's called a vegetative state, also known as a persistent vegetative state. It is considered Renshaw level 1 or 2, where here the patient's eyes may open spontaneously. They might have regular sleep-wake cycles, and they might be sluggish, or their arousal may be poorly sustained. If you put an object in front of the person, they might move their eyes, or they might be able to see the object or appear to see the person or the object that's in front of them. And if there's a loud noise, they might actually jump and appear startled to the sound. In a vegetative state, patients may moan, and they may cry or they may smile for no reason at all. It's not necessarily to a joke that you just told or a sad story. They just smile or cry. And as far as the motor response, patient in a vegetative state is going to try and withdraw from something that hurts them. They might also have some sort of non-purposeful repetitive movement, like shaking their head back and forth, or moving their leg back and forth, or shaking their hand. And any of these things would classify a person in a vegetative state as opposed to a coma. The next level up from a vegetative state is known as a minimally conscious state. Now, this state is considered Renshaw level 2 or 3, and again, we'll talk about exactly what that means next class. In a minimally conscious state, the person's eyes are going to open spontaneously. They might have normal sleep-wake cycles, or they might be a little abnormal. And as far as their arousal level is concerned, they can be anywhere from obtunded to normal. And in a minimally conscious state, they're going to be able to track objects and localize sound. That means if somebody is talking, they might actually turn and look to see who is speaking. They have some limited communication ability, but they're going to be inconsistent in their ability to decide yes or no, and just gesture and provide basic emotions that are appropriate. For a motor response, they're going to localize a noxious stimuli. So instead of withdrawing from it, they might try and swat you away if you do something that hurts them. They may actually reach for objects, and they may have automatic behaviors, such as something itches, they scratch it. Or if there's something in their eye, they might try and wipe it away. And this is the minimally conscious state, which is one step up from a vegetative state. And finally, the next step up the chain is called the confusional state. This is going to be Rancho level 4, 5, or 6. They're going to fluctuate in their arousal level. They may be excessively drowsy, or they may be hyperactive. They're going to respond very strongly to external stimuli. This is the patient population that you don't want to startle. If you do, their response is going to be pretty dramatic, and you're probably going to get hit. At this level, the patient is able to communicate, but it might be disoriented, and they're not going to have a very good memory. Their motor responses at this level are purposeful motor responses, meaning their intent is to take their hand and touch your nose, and they're able to do that and understand that that is what they're doing.